Hello and welcome to Health Matters on Channels Television. Thanks for joining us. I am Mary Alale Yusuf. The National Primary Healthcare Development Agency recently declared a state of emergency on maternal and child mortality. Its National Executive Director noted that in the last 25 years, Nigeria made the fifth worst progress among 20 countries that had the worst maternal mortality ratios by 1990. At 560 deaths per 100,000 live births, the maternal mortality rate has been described as alarming in light of the fact that many of these deaths are preventable. The primary healthcare system, which places emphasis on preventive medicine and healthcare services at the grassroots, is considered the foundation of the health sector. The sector plans to reduce maternal, newborn, and child mortality rates by 50% in 2 years. My guest is the Director General of the Cross River State Primary Healthcare Development Agency and the National Vice Chairman, Forum of CEOs, Primary Healthcare Agencies in Nigeria, Dr. Betta Edu. You are so welcome to the show.
Thank you so much.
In improvement in maternal mortality rates, we came behind countries like South Sudan, countries like Afghanistan, troubled countries. What is the matter? Why?
Okay, I would want to start on this note. Nigeria as a country should begin to look at the big picture of health system building. If the health system is working, then all other issues would follow. So it's like seeking first the kingdom of God and everything else will be added. Yeah. So the health system in Nigeria needs to work. Women need to have access to proper health care. Communities need to be informed. They have to participate in protecting themselves and their health care. Government needs to make commitments and match those commitments with the right actions. Our problem is not policy making. I'm sure if they put together all the policies made by Nigeria, it's more than the policy made in any other country in Africa, I bet. But the big problem is implementation, even on the smallest of things most times.
Smallest of things like enlightenment?
Even on enlightenment, even on health promotion, we fail. And so for me, I think it's a very bold step which the ED of the National Primary Healthcare took, saying in primary healthcare facilities, what is under me? How can I fix my house together? How can we reduce maternal mortality by at least 50%? And he's being very, very practical about it.
Okay, so now that you talk of practicality, there have to be some really wild strategies in place to reduce the rates by 50% in 2 years.
Yes. So first of all, we want to ask questions and hold people accountable. If people die in communities, if people die in primary health centers, sometimes those deaths are not accounted for in any way. So a health worker knows that she can afford to shut the facility and go stay in her farm or stay at home or discuss with her friend. A woman comes and dies there and nothing happens. A woman can show up in a health facility and the bad attitude of the health worker leads to the death of the woman or her baby. Nothing happens. Nobody's asking any question. So it's kind of going to be like a centered accountability process where from the national, there'll be daily call-outs to facilities, to communities to ask questions, why, trace the reasons and try to prevent them. Secondly, we have a huge window of opportunity with the Basic Healthcare Provision Fund, where funds will be sent directly to facilities to help improve them, improve the infrastructure, improve the manpower need, provide essential drugs and services, provide commodities that are needed, and also help build capacity of those who are delivering services, as well as account for community outreaches. Of course, we've been...
So we're talking about a lot of money here.
Yeah.
This basic healthcare provision fund, where is it coming from? What's it made up of?
Okay, so Basic Healthcare Provision Fund was being put into the National Health Act of 2014 and is to be collected from 1% of the consolidated revenue fund of Nigeria. So every revenue Nigeria has, 1% of it should go
To
to
health.
basic health care.
basic health
So, and then 50% of this money is supposed to be put into the NHIS, that's this, and then of course to the state health insurance scheme, which is supposed to pay providers either based on capitation or fee for service, depending on what is agreed. And then 45% is supposed to go through the National Primary Healthcare Development Agency, to the State Primary Healthcare Development Agency, and to health facilities.
Okay, so let's break it down.
Yeah.
Let's say that the 1% is 100 naira. So what you're saying is that 50 naira goes to NHS,
Yes.
NHIS.
Yes.
Then 45
Yes.
goes to state health facilities,
Yes.
villages,
Primary healthcare
rural
centers,
centers. And then 5 naira goes where?
5 naira goes to emergency treatment. Okay, so emergency services, ambulance services, and all of that. And then, of course, if we have other emergencies, there's some funds to respond to it. So that 5% goes through that gateway. But what is most important is that there are two very strong ways to help improve the health system. One is to ensure that there's increased accessibility, and which the PAC gateway would help to solve that. And the other one is to ensure that there's this social protection from the risk of catastrophic expenditure, which the NHIS, SHIS is supposed to help protect. Okay. So by that I mean, first, there'll be money for revitalization of primary health centers. There'll be money to the grassroots for their day-to-day operation, their outreaches to community. And at the same time, people can register under the insurance, enroll, register under insurance, and can have access to healthcare free of charge.
Okay, so this is a new initiative.
Yes, it is.
I want to ask, how do we make sure the monies go where they're supposed to go? Because you know we've had problems when we go down this route. Foreign donors are like, what are you doing with the money?
Yeah. So part of where the money is supposed to come from is also from our donors. Okay, so partners, development partners, donors are supposed to bring in some money. Some donors like the World Bank, Bill and Melinda Gates Foundation, the rest of them are supposed to bring some funds into this central purse. And then of course states are supposed to put in some monies into the same purse.
So it's looking more robust.
Good, it's looking very robust. But the problem now is accountability, and how are we spending the money, and how is it getting to the root? For me, I would subscribe that first and foremost, we should encourage a bottom-up approach. So health facilities should be able to plan, set their work plans, get their budgets, and get that approved, both from their local government health authority to the state primary healthcare development agency to the national primary healthcare development agency. And then money sent directly to those facilities. And of course, after the monies have been sent, there is that supervision and monitoring, following up to see whether the monies have been used judiciously. That is only when you can now approve another money to go to the same facility.
Would it be better to send the money straight to the facilities involved, or to send them facilities? That means you've bought the things already and you give them the drugs.
So part of one of the things which I want to really raise using this opportunity is to first stress the fact that, please, it would be better for facilities to plan and procure by themselves.
Okay, and why is
based
that?
on their local needs. The need in my village in Cross River State is not the need in your village. It's not the need in Nasarawa State. It's not the need in Sokoto State. So facilities should be allowed to build that capacity to be able to fend for themselves. Say, okay, I need more manpower, I'll hire. I need more, give them that autonomy to be able to operate. And that way we can make the system more functional. Secondly, we are trying to appeal that we should reduce bureaucracy with this money and with the implementation of this basic healthcare provision fund. There's no need of creating a separate secretariat, creating a separate building and putting people there. Their work is to, they will have a budget and they're going to spend money from the basic healthcare provision fund doing things that would not add up. It's reducing from the money. It's reducing from the purse.
Are there plans to do that?
Yes, there are plans to do that. The law has stated which money should go. National Primary Healthcare Development Agency handle this. National Health Insurance Scheme handle this. The Federal Ministry of Health handle this. Let's not create too many bureaucratic processes, because now you're adding another line to it, saying, okay, the facilities will write to the local government health authorities, then to the state primary healthcare board to verify, and then to the National Primary Healthcare Agency, and then from there to a secretariat, which will now be seen by the national. Too many bureaucracies, and things will not move. They're not moving. Unfortunately, I'm not, from the information which I got last, the bit of it which is supposed to come from the federal government has not been released completely yet for this project to run. So it's high time we put our monies into it. This is one of the ways to help us progress towards universal health coverage, and Nigeria needs to show that commitment. The Federal Ministry of Health and those who are involved need to show leadership, very selfless, egoless leadership at this point,
okay,
because millions of lives are involved.
We can't ignore, which is manpower, capacity building. No matter how much capacity we seem to be building, it's going out of the country. So how is that going to be handled? How is that going to be tackled? Right now, the figures we have is that we have one doctor to 5,000 people or more.
Yeah. So presently, we have one doctor to about 5,500 persons. And WHO standard says one doctor to 600 persons to help us. Of course, we're discussing universal health coverage. We're discussing access to health care. Nigeria presently has, let's say, about 450,000 health workers.
Okay.
Okay? That's both doctors, nurses, everybody put together. Doctors are like 35,000. And even if Nigeria is to produce 10 times this number for the next 10 years, we would not have arrived at the point where we would be able to achieve universal health coverage.
Now, there lies a major problem.
Good. So our solutions would be, one, like I said, let's look at it holistically. It's a system. So from the education, from the employment, from all of those things need to be looked into. When you talk about the education, our institutions, each state should be mandated to have a certain number of institutions that churn out health workers at different grades. Okay, so both from the lowest, the CHUs, the JCHUs, med lab technicians, pharmacists, then climbing up to the nurses, school of midwifery, and the rest of it. The red tape is too thick and it's too long. We need to reduce those things. There's no gain saying that a medical school is graduating 40 out of 200 persons who start for the final exam, and you're graduating 40. Or 90% of people have failed an exam. It doesn't show that you're a better teacher.
Standards are too high?
I'm not saying that the standards are too high. I'm saying that it should be less subjective.
Okay.
Because most of those exams are based on the examiner. They are subjective. They should be less subjective and more objective, and then more accommodating and flexible.
So more people pass,
exactly,
graduate more doctors,
exactly,
and fill more
to fill more positions. Even the accreditation process for some of these schools should also be looked into, so that we can have more people being brought into the health system. Secondly, the method of employment. If we must achieve universal health coverage and we must increase access to health care, we should look into the method of employment. We're having an employment. The Cross River State Governor, Senator Ben Ayade, approved 1,000 health workers to be employed into the primary health care system. Okay? And we are employing in such a way that first, we're employing people who are from a particular location, who are
I need to hold you right there.
Okay.
We'll come and continue from there when we come back. We need to go on a break.
Sure.
Stay with us. We're coming back from a short break. Welcome back. We're talking about how to improve primary health care, which is considered the foundation of the health sector. Now, to call in and ask questions, you can call 0808-054-2233. That's 0808-054-2233. You can also tweet at CTV_Mary A while the program continues. There's a tweet here from Betta Uche Jeso. He has a list, and he says, to improve, employ, retrain, and motivate qualified health professionals like doctors, pharmacists, med lab scientists, nurses, etc. And then he says, establish a functional medical laboratory Something we should talk about. In all PHCs, manned by med lab scientists and ensure quality. Now, we can talk about that as we go along, but I want you to finish this method of employment that you were talking about.
Yeah, so for us now, the idea is to employ people and send them to work where they come from and where they can be held accountable. So if I'm employing you and you're from this village, the chief
send
knows
me right
you,
there.
Good, I'll send you right there. And then you sign a bond when you're coming to take the job. You sign a bond that you're going to work in that village for at least a certain amount of time, between 2 to 3 years, before you can be posted out. So if you want that, you take the job. If you don't want it, you can let the job be for those who want it. And then, of course, you must motivate health workers.
That was coming to that. See, people don't want to move to a corner of the world where they don't get anything.
Where nothing works. You must motivate them. You must give them incentives. There are countries, when you see the PLAB exam and you have over 600 doctors writing one PLAB exam, or you have an interview.
Exam?
Okay, so it's the exam for a doctor to go work in the UK. Okay, or you have an interview for Saudi Arabia
they flood those.
And the whole place is flooded with art. It's just because the enabling environment is not there, the right incentives is not there, our voices are not being heard, and we're not given the right environment to thrive. So nobody wants to work where he's not being appreciated. And so that's why they keep moving and moving. But then
now my question
we need to do more.
This basic healthcare provision fund take care of the motivation of these doctors who agree to go to these corners of the world?
So now that's the more reason why you should give some level of autonomy to health facilities to plan for what they want. So if they know that they have a huge client inflow and that the presence of 1 or 2 doctors will make the difference to protect people more, provide the services which they want to, then they have the money to hire them.
Would the money be enough?
Well, they have to choose their priority. There's never enough. So you have to place things based on scale of preference. This is what I want most at this point. Then after that, this and that. But at least there should be, of course, they have said that part of the monies going to the facility, a good portion of it should be dedicated to both training of manpower and contracting manpower, so employing people to work in those facilities.
Okay, what can you say about the spread of PHCs across the country? I know there was a time they were talking about 10,000 PHCs becoming functional and everything. But that aside, what do you think about the spread? Do we have enough? And are they everywhere?
Okay, so first and foremost, I say we do not have enough primary healthcare centers in Nigeria to be able to achieve universal health coverage, and I can be quoted on it. Secondly, the spread is not right. Most times it's been influenced by politicians, what they want and all of that. And then to make matters worse, like I had said earlier on, states are struggling based on their strength, their financial strength. So it's been left to states to say, okay, what can you do to make to revitalize primary healthcare? What can you do? I give kudos to the ED of the Primary Healthcare Development Agency, because he's been doing a lot, interacting with governors and trying to make them see why they should invest in primary healthcare, even at the Governors Forum. But then beyond that, I still believe strongly that the federal government needs to commit to the 10,000 PHCs, which they said they will make functional, and make them functional. I think it's important that we do that. It's very, very important. At the beginning, of course, you saw the president when he went to one of the primary health centers in Abuja, outskirts, and made that.
I've got to take Femi. Femi is calling in. Hello, Femi.
How are you?
Hello, Femi.
Hello.
Yeah.
Yeah, how are you?
Great. What's your question?
Yeah, I just have a contribution.
Go ahead.
Yeah, you see, while we appreciate the fact that for us to have this universal health coverage, there are a lot of things that have to be put in place. I can appreciate the fact that you are looking at the funding. The funding is very important. But I think we should also look at the end users of these services, the communities. Over time, community members have not been involved in issues, especially health issues that affect their lives. Number two, Over time, we have been experiencing vertical programs at the expense of integrated programs.
Okay.
And both often too, unnecessary administrative bureaucracy has not made us to achieve quite a lot in primary healthcare in Nigeria. Okay. I have a very strong feeling that until we all sit down as stakeholders in this system, put an into how best do you think we can handle this situation? Because most often you see somebody sitting in the armchair in Abuja and throw out programs to the village. Exactly. Number two, you also find out that most of these programs are not coordinated. See, at the end, you find that community members get confused. Today's malaria program is coming from Federal Ministry of Health to a village. Okay. Tomorrow it is tuberculosis. So at the end of the day, it is the same village.
All right, thank you so much, Femi. Let's have this is a lot.
Yes.
He's talking about how they can contribute, first of all.
Yeah, so first and foremost, I think Femi is correct. I started by saying our biggest problem is we do not look at it as a health system.
Okay.
We like vertical programs, HIV this, malaria this, family planning. We love those things.
So how do you integrate?
Integration is simply health system strengthening. Okay. That means if you are looking at an individual, you're trying to give everything at the same time. A woman shows up in the facility. You're asking, what are all the services available that this woman can benefit from? So today at this time. So you're not there because you want to give her just malaria treatment. Neither are you there because you just want to give her HIV test and then you're gone, or you want to issue family planning. No, it's an opportunity.
Let's take a call from Shomolu.
Okay.
Hello.
Hello.
Hello, Mr. Jimo.
Yeah, hello.
Hello. Go on.
Please, I just want to contribute to what you have been saying.
You have to do that quickly.
Yes. Thank you very much for that enlightenment. But the only area I think I need to emphasize a bit is about this issue of the grading of the doctors, that they should look into it, maybe they bring it down or something like that. Because the way I look at it is that if somebody is not qualified, and you said because we need them more, this is exactly what is happening in teaching profession. So definitely there's not going to be the quality service, and it's even dangerous, very, very dangerous, if we look at the repercussion. So that's just what I want to contribute.
All right, thank you very much.
Okay, so we're not saying bring down the standards. We're saying there's what they call tax shifting, okay? So train more people in more other sub-medical sectors, areas which can help do some of the tasks which the doctors will do. Okay. And at the same time, bring up more schools where doctors can be graduated from. And then when he mentioned the community engagement, this is one of the focal points. In fact, I feel when they say the building blocks of the health sector, one of the things they missed out of it is community participation. It's more important than anything else.
How do they participate? What do they do?
Good. First, information, health promotion.
You have
the information have to go out to communities. We must engage with traditional rulers. We must engage with gatekeepers and get them involved. And we are doing that through the Ward Development Committee across the nation. Okay. So we're creating Ward Development Committee.
Thank you very much, Dr. Betta.
You're welcome.
It has been very engaging. Thank you so much for coming on the program.
Thank you
and
so
thank
much
you for listening to us from home. Enjoy the rest of your day. I am Mary Alale.